Thanks, Ellie, and the other chairs for having me. This is a great educational format, and I'm glad to see so many participants from all parts of the world. Today, we'll spend a few minutes talking about adolescent idiopathic scoliosis. And as we know so far, it's a three-dimensional deformity of the spine, with the essential lesion being a coronal deviation of the spine of about 10 degrees or more. But also within that three-dimensional deformity, you have to look for an axial plane rotation and the other essential lesion in the sagittal plane, which we're learning more and more about, thoracic lordosis, as pointed out by the red arrows. We don't know yet the etiology. It is genetic, it is hormonal, it is influenced by the environment. But what we do know is it's probably an anterior overgrowth of the spine causing a buckling, a column buckling in multiple dimensions. It's typically associated with progression during the pre-adolescent growth spurt or peak height velocity. It is associated with loss of kyphosis, or in fact, lordosis at the apical segments. And because that spine is rotated, it's subject to abnormal dorsal shear loads, which can also aggravate the deformity. And with long-standing deformities and asymmetric growth, you get a vicious cycle of bone remodeling, bone wedging, disc deformity, and disc degeneration. And all of that is responsible for the biomechanical phenomenon that we see. What's typical in my clinic would be a young girl who's about 11 years old, skeletally immature, comes in with a 20-degree curve. The family is distraught. They're distraught at the diagnosis. They know what it might mean in the future. How did they miss it? And we're acting as fortune tellers most of the time to try and understand where this curve is going. Prior to skeletal maturity, there's obviously a chance of progression. This disorder affects 3 to 4% of the US population. But what we have to remember and counsel our patients is that most small curves remain small. Only a small percentage of those curves like this that present will actually progress to need surgery. But yet we spend a lot of time, unnecessary worry, and x-rays monitoring a very large percentage of the patients who will actually never progress. What we need are better ways to determine prognosis of these deformities. We have better ways of staging skeletal maturity and predicting height velocity, such as the standard staging method, which here is stage 3, showing that all of the physes in the distal phalanges are open and they're as wide as the metaphysis. And I urge you to look at his seminal work to understand a better way to predict skeletal maturity. We also understand that there are some predictive ways looking at the sagittal plane versus thoracic versus lumbar curves, and we've shown that they're subject to those abnormal dorsal shear loads. And now with three-dimensional radiography, we have other ways of looking at the spine in 3 dimensions and looking at apical rotation, disc wedging, vertebral body wedging, in order to be much more accurate at even the first and perhaps second x-ray to determine whether that patient's going to need progression. I wanted to form a foundation before we talk about surgery about how we manage AIS, and then we'll go on to 2 cases which I think illustrate a lot of the fundamentals of surgery. First of all, like I mentioned, we observe many patients with small curves. We bring them back on a very routine basis, perhaps every 6 months, perhaps only annually, to limit the amount of radiation and still determine whether that curve is going to progress. If it does progress, perhaps to 25 or 40 degrees, we can use a brace. And I'll show you some convincing data that bracing works, and bracing is very effective for our adolescent population. And finally, if the curve exceeds 45 or 50 degrees, we have many different types of surgery that are available to those patients with very good outcomes. The seminal paper that proved that bracing works from Stu Weinstein and colleagues in Iowa, we were one of the centers to enroll patients in that study. It was very well designed, initially level 1, then had a selection arm in which you see the criteria here. The study was stopped before completion because there was a clear benefit from bracing and it was unethical to proceed, with an efficacy anywhere from 72 to 75% of patients who wore a brace avoided surgery. Furthermore, there's a dose-dependent response of bracing. The more you wear the brace, the better effect you get. And so our goal now is to brace people full-time to get the best effect at avoiding surgery. So here's case 1. And this is a 13-year-old female, and this is her first presentation film. You can see that the main thoracic curve is about 59 degrees. There's a proximal thoracic curve and lumbar curve. They're not measured on this film, but subsequent films. But this is the first presentation. So just based on what we discussed, would you think that this curve can be observed, should be braced, or we should immediately proceed to surgery?
Perfect.
Go
And
ahead
we'll
and put
ask,
your responses in the chat box, and we'll see sort of what the majority has to say.
and while they do that, Suken, quick question is, what's her skeletal maturity again?
So she's exactly in that area where she is skeletally immature, but you don't know how skeletally immature she is because I haven't given you any of the demographics or any of the skeletal markers that are really important. But this is just because of the sheer Cobb angle. I think 2 out of the 3 choices should not be entertained based on the presentation here. Unlike the first patient, which was 20 degrees there, you really could have observed her because she was skeletally mature, but the curve was less than 25 degrees. I think in this scenario, the clear recommendation would be for surgery because we can't brace her unless she was very young. I think in the early onset population, I routinely brace curves this big in an effort to buy time rather than apply growth modulation techniques. Perhaps we can wait a little bit longer until they're more applicable for a definitive fusion rather than growing rods, for instance. But in this case, we recommended surgery. So these were her preoperative studies. The first thing you notice is that the curve progressed a little bit. It's because she's skeletally mature. So here I've described the radiographic parameters that are very important to us to look at. Her triradiate cartilage around the hip is closed. That typically means someone has exceeded their peak height velocity or is over their peak height velocity. Risser staging, which we used to use as the old way, indicates that she's probably skeletally immature. There's the iliac apophysis has just appeared. She's standard stage 5, which means she's, yes, beyond peak height velocity, but still has some substantial growth remaining. There's an overwhelming risk for this curve to continue to progress. She just had her menses, but most women grow about 18 months after their first period. And so that's not a marker of lack of growth. It's a marker that the peak height velocity is probably over. So I think that all of these things are concordant. We see many patients discordant, in fact, where they haven't had their period, but they're done growing, or they have had their period, but they still have significant growth left. That's why skeletal markers like the hand x-ray should be your primary go-to until we get something better, like a hormonal test or a spit test. And just by her social history, she's in 7th grade, she participates in sports, she's very active.
So Suken, a question, if you don't mind. So those 2 x-rays are the same patient. And what was the duration of time that led to that, the interval between the 2 x-rays, and why did you wait and not intervene surgically with the 59-degree Cobb angle?
This was about 2 or 3 months. And most of the time, that's the amount of time we need to get a family on board, book, in terms of what our weight is and so forth. Sometimes people want to wait a few months until the summer or school's out. I don't remember the particular circumstances, but I do know it was about a 3-month difference between her presentation film and these films, which were done just a week before surgery.
Got it. Thank you. So for the folks in the chat who recommended surgery at the 59-degree Cobb angle mark, that is a correct choice, correct?
Correct. And our colleagues in Canada who might have a 6, 8, 12-month waiting list, the curve can be completely different when that patient actually shows up from surgery. So many of these kids, we titrate how much time we can wait based on their risk of curve progression, because sometimes that changes the nature of the surgery. These are the bending x-rays, and I prefer the lumbar bends to be done supine with maximal effort. You can see her ribs are actually touching her pelvis. This is a good bender. The other bender is done over a fulcrum. This is a 6-inch PVC pipe wrapped in foam, and I think that demonstrates the best effort without the patient being involved in how far they can bend. Obviously, in a 13-year-old girl, these curves are generally flexible, but the lumbar curve is particularly flexible, and it indicates that it's a non-structural curve. Don't be misled by the thoracic curve perhaps measuring less than 25 degrees. It doesn't even matter what it measures on this bender. This is just to tell me what we might be getting in surgery. But that's automatically the structural curve. The largest Cobb angle is the naming curve pattern for the Lenke classification. So that's our next question. How do we classify this curve based on the main thoracic curve size the lumbar curve and proximal thoracic curve flexibility, the sagittal alignment, whether they are kyphotic or not, and then those bending x-rays.
So Koi, let's ask the audience how would they classify this curve? See what people think.
Yeah, so far we have one vote for 1C, but not a lot of action in the chat box.
So the center sacral vertical line, as indicated by the solid black line that my arrow is on, if that passes between the apical pedicles of the lumbar curve, that's an A. If it's touching the apical pedicle, that's a B. And if it's completely off to the side, that's a C. Now, this lumbar curve is very short. It's really only these two segments, and it passes between that. So the lumbar modifier on this curve is going to be an A. The main thoracic curve is the largest, so that makes this automatically a 1, 2, or 3, or 4, and 5 and 6 are eliminated. The proximal thoracic curve is not stiff, and it's not kyphotic greater than 20 degrees, so that's non-structural. The lumbar curve is not structural because it's not stiff and not kyphotic. So this is, in fact, a Lenke 1. The lumbar modifier is an A. And as we'll see later, there's actually a subclassification of these Lenke 1A curves, which we'll get to in a moment. So the Lenke 1A curve classification, and the minus means that they are hypokyphotic, and actually there should be some attention paid to restoring kyphosis. I don't generally get MRI scans on idiopathic patients, but this girl showed up with a large curve with a very reliable family history, and we just wanted to make sure there was no Chiari malformation, apical syrinx, or tethered cord, and that's why these three sections are illustrated in a very limited format, showing that the spinal cord is not dysraphic, and this is truly AIS.
Hi, Suken, I'm going to interrupt. I apologize. Just a quick question, because I think a lot of people in the audience may have this question, which is, what are your indications for obtaining an MRI in a patient with you suspect having AIS? What are your indications for the MRI?
I think generally most people would agree an atypical curve presentation, if they're kyphotic or if the curve goes to the left or they're very out of balance with no compensatory curve, that really raises my my ears or my radar into thinking there might be a syrinx or a syngomyelia or a neuromuscular type of curve. If there's pain out of proportion, most AIS patients are not having pain. That's in contrast to our adult spine deformity patients, so that's generally their main complaint. We will get an MRI to rule out an osteotomy, but it's really an atypical curve pattern with poor decompensation mechanisms or kyphosis at the apex that I would get an MRI for. I think the relative indications are male, rapid progression, some of those soft signs, and obviously anyone who has an abnormal neurologic exam, whether that's asymmetric abdominal reflexes, cavus foot, asymmetric lower extremity reflexes, atrophy, those are all pretty decent indications to get MRI. These are the clinical photos. I want to point out that she has a trunk shift. Her thoracic spine is in lordosis. With the forward bend, you see the asymmetry of the right thoracic cage over the left. And then the spine moves quite normally in the lumbar area, but most of these patients lack a lot of thoracic spine flexibility. And that's something to point out to the parents or the patient, that their thoracic spine doesn't bend very much anyway. And doing surgery on a patient like this isn't going to take away appreciable motion as they're demonstrating right now. We like to use the low-dose stereoradiography measurements to plan our surgery, understand the sagittal plane, where the apical rotation is, and really form a preoperative plan. In the lower right, you're going to notice that this curve is very deviated to the right. This tells us the plane of maximal curvature is right and slightly posterior. And these are the things we want to reassess and correct during surgery when we're looking at 3 dimensions. So this is a surface rendering of the same patient standing up, showing you anterior axial and the true lateral. What the true lateral means is we've taken out all the rotation at the apex and just stacked the vertebrae, and that's how much lordosis she actually has. That obviously looks very abnormal, but that's her true sagittal profile, and that's the key to assessing 3-dimensional correction. So if we put all that together, What's our plan? And this is the deliberate methodology that we teach our fellows to go through for every case. So it has to be meticulous planning so nothing is missed. We want to look at the classification to decide which curves need to be fused, the remaining growth to understand what growth might do to this patient, whether the patient may add on or be at risk for crankshaft. What's the flexibility? What's the sagittal plane? Which levels are we going to do? The upper instrument inverter typically depends on how high the curve is and whether that proximal thoracic curve is structural. And then I look at shoulder balance. If the right shoulder is up, we might be able to stop at T4. If the left shoulder is up, we have to go higher and stop at T2 in order to level the shoulders. If the shoulders are even, or there's a large thoracic component that we are going to correct, then T3 or certainly sometimes even T2 would be the proximal level. The lowest instrument level is much more straightforward. I think Lenke's idea of using the center of sacral line and the last touched vertebra is an excellent one that holds up in virtually every curve pattern, and that's drawn here in the solid black line, and that intersects at L2. Whether we use pontiostiotomies or not, for me the answer is easy. I virtually always do it, and I'll explain why. And then you have to know about your rod materials, diameter, implant systems, and strategy, and what your implant density is going to be. We heard an excellent paper last night by Noel Larson during the POSNA virtual meeting, which highlighted looking at lower implant densities for many of our flexible AIS patients, and so that should be certainly taken into account. So here's an opportunity for some more questions. We already know the classification. The remaining growth, I would say, is moderate. The flexibility is good, very typical of an AIS patient, but the sagittal plane is hypokyphotic or frankly lordotic in the apex. What levels are we going to do? Perhaps that's a question we should ask in the chat. What should our proximal level be based on this appearance, and what should our distal level be based on these films? And then how many people would do Pontes for this patient and why? And what sort of rod materials and implant density should we use? So I'll just pause for a few seconds here so you can tell us the levels, whether you're going to use Pontes, and what sort of implant you would use.
Can you show us the X-ray again, Suken, while Coy polls the audience? And the question, and I also wanted to follow up with a question as folks type in their responses, most certainly about the UIV and LIV. Can you just explain to the audience what you meant by crankshaft phenomenon and also add-on phenomenon?
Yeah, so there are two different things. The add-on phenomenon is much more common. And that would be if I chose a distal fusion level that was a little bit too high, trying to save levels, and that patient grew, and the lumbar curve progressed, you would start to see a recurrent trunk shift and perhaps even distal junctional kyphosis, and that patient might need to be revised to a lower level. And it's not just going to be one lower level, it's probably going to be two lower levels to gain control of that patient's trunk and reestablish their coronal alignment.
So there's a variety of opinions in the chat box, but generally the consensus is T3 or T4 down to L2 or L3.
That's great. And the reason there's variability is this is not an exact science. Maybe with machine learning in the future and big database registries like the Harm Study Group will really be able to wrap our heads very reliably on fusion levels. But that is definitely the most variable, most common variable when you're asking surgeons which levels to fuse. So I'll tell you, this is what we thought about. T4 to L2. Yes on the Pontes, and we'd like to use a 5-5 rod system in a very thin patient like her with uniplanar screws and a high implant density because we have a lot of apical rotation and we have a lot of kyphosis that we want to restore. This is an intraoperative photo of Ponte osteotomies done with an ultrasonic bone scalpel. And what you can see here is that the posterior elements are disarticulated. So the steps are taking off the inferior spinous process, taking away the ligamentum flavum, and then cutting out towards the pars to gain access into the foramen. And you can do that with a Kerrison rongeur and with an ultrasonic scalpel device, which I'll show you in a video. Why routine Ponte? I think for your audience, guys, you're probably not afraid of being in the canal, but with traditional training, sometimes people are a little bit anxious about being in the canal, but I think you have to get familiar with it, and you have to have that in your armamentarium. Traditionally, the bane of very large curves, I think the routine Ponti has a lot of benefits, even for a curve like this, because we can restore the kyphosis, we can get better derotation, we're not depending on our implants to do all the correction, and it's actually much safer for the spine to be more flexible before we apply large loads during the corrective maneuvers. I also use the techniques of differential rod contouring, and in this patient with excellent bone density, we can use uniplanar screws rather than polyaxial screws to get very good coronal and axial plane correction, but still retain the ability to fine-tune the kyphosis in the sagittal plane.
There's a question from the audience regarding whether you can comment on tethering as an option.
Personally, I think this curve is too big, but one of the main limitations is how far down the LIV is going to be. And there it requires some sophisticated techniques to take down the diaphragm if you want to stay minimally invasive. So for thoracoscopic vertebral tethering, I like to stick to the T5 to T12 levels, and it makes the operation much more straightforward. Furthermore, she doesn't have a lot of growth remaining, albeit some. I would have liked her to be at least 1 year younger in the skeletal maturity department in order to take advantage of remaining growth to correct that curve further.
And I can't help but put a plug in for our conference. In full disclosure for the audience, we are also going to have another phenomenal speaker and a session just for anterior vertebral body tethering, because it is an exciting, potentially innovative non-fusion option. But I think Dr. Shah would agree that for 95% plus of the AIS cases that we currently see, this posterior-based approach is currently the standard of care.
So just a word about differential rod contouring. This is our workhorse to derotate the apex. And so for a typical right thoracic curve, I like to put a lot more kyphosis in the left rod in order to pull that apical lordosis up. And the convex rod on the right is very flat in order to roll that spine and get that rib hump down. And so you'll see this illustrated in the video. This is 2 rods. The one in the rod holder, which I'm going to rotate, is going to be the left rod for this patient. And the right rod, very flat, is going to go over the convexity or the right side of the patient. And here I'm just rolling that rod to show you how disparate these 2 bends are. If you're bending your rods identically for a patient like this, you're going to be very unhappy with your ability to derotate the spine, but most of all, you're going to be unhappy with trying to restore kyphosis. So the steps are to classify the curve, which we did, get a preoperative 3D assessment to really hone in on what we want to correct. What are our goals? What are the expectations of the patient and the family? Mobilize the spine with radical facetectomies and Pontis at the apex. Keep the exposure as bloodless as possible and as quick as possible. And then intraoperatively, our 3D correction is going to be relying on a high implant density, that differential rod contouring, and certain maneuvers like the vertebral body derotation method to correct that axial plane, and distraction on the concave rod to restore kyphosis. And then putting it all together, it's not like I do this, I do this, I do this. A lot of it's happening together, which is why the video is so important to show you. And then ultimately, postoperative assessment. Did I do what we set out to do? And if not, what happened? You've got to audit your practice. You've got to be critical of your results. That's the only way you're going to get better. This is an intraoperative photo of a patient who had a very good correction. And you're not looking at the sponus processes to be lined up because they can be very dysraphic. You want to see the screws pointing towards midline. You want to see kyphosis reestablished in that mid-thoracic spine. And you want to see very little deformity if you're interested in 3-dimensional correction. This allows you to save levels. It avoids having to do a thoracoplasty, and it really keeps the patient well aligned for the future and keeps the lumbar spine protected from the aging process and hopefully avoiding a second surgery well into adulthood. So this is our patient. This is her first erect film, which I typically do at about 4 weeks. And here the judge criteria are the shoulders level. What are the regional alignments of the cervical spine and lumbar spine below our instrumented segment and above our instrumented segment? Is there restoration of kyphosis from that apical lordosis? Is the rib gone? Are the ribs more symmetric, right and left rib cage? And are the rods superimposed on each other? I showed you how different those rods were bent. Here, they look the same. And that's because they acted exactly how he wanted to be. The apical lordosis was pulled up, and the convex high side was pushed down. So now a word about the LIV. This may have been confusing to some to see that subclassification. Here's that center sacral line drawn through that. You can see it passes through the apical to the pedicle of L2. Why did I not choose L1 when that lumbar curve came way over? In this particular curve pattern, you have to go to that one level lower when you're in between. Otherwise, these patients have about a 25% chance of adding on later. And remaining growth is a big risk factor for adding on. This is a great paper showing you that difference between the Lenke 1AL curve, which has a curve component going back to the left, and L4 is tilted to the left, versus our patient who has a 1AR curve where L4 is tilted to the right. This is an overhang curve. If you're familiar with the King-Moe classification, this is a King 4 curve. They're both labeled as Lenke 1As, but they have a very different lowest instrumented vertebra. And this is a very important concept and a mistake you don't want to make. And what this shows you is for the 1AR curves, the fusion level has to go more distal when you're in doubt to protect that patient from adding on later and getting a trunk shift.
Suken, thank you. That was an excellent case. I do have a follow-up. We have a few follow-up questions from the audience. I apologize to cut your cases a little bit short. That's our fault from the timing perspective. But if we can sneak in a question or two from the audience, if that's okay with you. The first one, Koi, I think there was somebody asking about selective thoracic. If that can you tell us why you think or which cases you think selective thoracic fusion are appropriate?
Yeah, the next case is actually all about that. You want to skip ahead to that?
I think if we can do it quickly, that would be great. But that would be
just. So these are her three-dimensional views. Case 2. So this curve is a 61-degree main thoracic, 40-degree lumbar. She's skeletally mature. There's virtually no risk of add-on or remaining growth threatening our choice to go a little short. We have to find out what activity she wants, look at the lumbar flexibility, and look at her truncal appearance. If she doesn't mind having a little bit of waist asymmetry, she's the perfect patient for a selective thoracic fusion. So here the curve classification again is in fact the Lenke 1, but it's the C lumbar modifier that's most appropriate for selective thoracic fusion, where you're getting the biggest bang for the buck by doing a short fusion and leaving the lumbar spine alone. And these are her postoperative films. So a selective thoracic fusion is defined as L1 and above for this 1CN or 3CN curve patterns, which would otherwise drive you well into the lumbar spine, sacrificing levels, sacrificing motion, and perhaps having to see Dr. Jones in the future for low back pain and junctional degeneration. And the best patients for that are patients who have these ratios between thoracic and lumbar curves of greater than 1.2, where the curve magnitude of the thoracic curve is bigger than the lumbar, thoracic curve is stiffer than the lumbar, and you're not at risk for lumbar decompensation.
Got it. Thank you. Thank you. That was very helpful. I think it's all about having that discussion with the patient and knowing what. Usually it's a she or he, but usually it's she and her family are willing to live with. But you're right. I did hear that also as well from many others, that a lot of people think the 1A is appropriate for selective thoracic, but it's actually the 1C, not the 1A.
Well, the 1A is always going to be a thoracic fusion, so that's not really a push. The
Right.
push is trying to avoid doing the lumbar spine.
Yeah. How do you save levels down below? Listen, this is great. We always find out that we can spend a whole hour with one presenter. So we apologize. We had to cut your second case short, Dr. Shah. But thank you very much. You're our second pediatric orthopedic speaker, and it always just it always kind of invokes a lot of discussion, a lot of questions. So on behalf of everyone, I want to thank you for showing those two cases and for giving us an overview of the basics of AIS. So thank you so much.
Thanks, Elliot. My pleasure.
We're going to switch gear now, and we are going to now go from pediatric to adult to show you kind of some of the issues we face with our adult patients. And I'm happy to introduce again Dr. Kristen Jones, who's a assistant professor of neurosurgery at University of Minnesota. Kristen, thank you for joining us.
Thank you so much, Ali. to follow Suken in a presentation, so I'll try to do my best here. Today we're going to be speaking about some very difficult problems in adult deformity surgery, and I want to start out, sorry, not advancing, start out by introducing the concept of doing a PSO or a 3-column osteotomy in a patient who's had a prior anterior instrumentation. Nowadays, we're reserving 3-column osteotomies for rigid deformities. And the particular case we're going to talk about has a very rigid deformity with significant instrumentation. And then we're going to talk about a novel salvage and repair technique for proximal junctional failure that actually involves doing an osteotomy, hopefully as nice as Suken's. He demonstrated the Ponte osteotomy, but combining that with a transforaminal thoracic interbody fusion to repair junctional failure. So unlike in pediatric deformity and AIS, adult deformity is plagued by a very quick junctional failure, as many of you might know. And so we're going to discuss this case of a 70-year-old woman. And prior to coming to our institution, she has a fairly typical story of multiple prior surgeries. She's had anterior interbodies and instrumentation from L3 to the sacrum, and has existing T12 to iliac fixation. And of course, you can see on her standing films why she has severe back pain and standing intolerance. And just to demonstrate the typical harbingers of sagittal deformity, she's got the hip flexion, knee flexion. You can see that her pelvic retroversion or her pelvic tilt is nearly maximized. And she also has thoracic hypokyphosis, so she's extending through her thoracic spine to try to achieve upright stance. And so again, fairly typical for sagittal deformity. And so I'd like to take a poll at this point, assuming that she had adequate sagittal alignment, which we'll measure shortly and find that she does not. In addition to getting optimal sagittal alignment, what strategy is everyone using to try to decrease the risk of proximal junctional failure? So there are multiple different strategies and just listed the most common ones here. And just curious, Koi, if you wouldn't mind polling the audience to see what everyone has to say about that and then letting us know what the answers are. And we'll sort of keep moving until I'm told otherwise.
Kristen, I'll ask you a question while Koi keeps an eye on the chat room and tells us what the audience thinks. Can you, and I apologize if you went over it, but just can you very quickly remind our audience, what's your definition of PJK and PJF and what's the difference?
That's a really great question. There are variable definitions. In general, proximal junctional failure is reserved for either a fracture in the elements, in posterior elements, or the vertebral body themselves, which should automatically qualify as failure. The definitions of proximal junctional kyphosis vary significantly. Some are as stringent as less than or 20 degrees at the proximal level. A lot focus on the degree of change from what was present preoperatively to what was present postoperatively at the angle of interest. But if you read different papers, you'll definitely find multiple different definitions. So it's really an important question, and to define better is something we should all be tasked with. Perfect.
Absolutely. No, thank you so much. I just thought it was important for, we also have a lot of residents with us, by the way, on the conference. And like you said, it's very variable, but for a lot of people and for us, it's like, PJK, you're probably going to see it, a very high chance of seeing it up to 30–40%, but that doesn't mean it's surgical. When it becomes a failure, PJF then becomes surgical. Do you agree with that?
Thank you. I think that's a really important point. PJK is very common in deformity surgery, as you mentioned, and the vast majority of people are okay without a revision. When it progresses to either a fracture pattern proximally or progressive deformity, progressive kyphosis, or significant pain that's not responsive to anything, then we would consider it a surgical candidate for revision. But very important to realize, as you said, that not every patient with PJK needs surgery to revise that. Thank you.
Of course. Koi, what does everybody think?
So, a lot of different votes, but I'd say the most common responses are for C, being hooks, and E being combination approaches.
Okay, there's a great deal of interest recently in podium presentations as well as publications focusing on the biomechanical advantages of different of these strategies. And there were a great recent paper published about using UIV+2 if you're going to use a posterior tether. So traditionally we might think, oh, we'll just tether a level above, but that's really not optimal. Really 2 levels above is. And also that same study showing that you can over-tension someone by adding a tether, and you can actually induce failure that way. So again, important. This is a space that needs more definition and work, but again, it's a large focus in deformity surgery right now. So, and thanks for everybody that shared their thoughts on that. So moving forward, just to do some specific sagittal plane measurements, and forgive me if I'm overstating things, I'm just gonna go through the basic sagittal deformity measurements that we would want to employ in an adult deformity patient. And so first, of course, noting where the patient has existing instrumentation, in this case, T10 to iliac, we would absolutely want to evaluate closely which levels are actually fused, because just because something's instrumented doesn't mean it's fused. And that's very relevant for us understanding how we're going to manipulate this intraoperatively. Someone who's fused through all three columns is, of course, going to need a different procedure, a different type of osteotomy compared to someone who has a pseudarthrosis and is fairly mobile. So again, I want to point out that there's at least a 40-degree proximal junctional kyphosis, and it's a failure pattern in that there's a grade 2 spondylolisthesis here. And this is a fairly reducible deformity when the patient's flat, the spondylolisthesis reduced. But as everybody here knows, the spinal cord does not take kindly to mobile spondylolisthesis. And so we definitely had this patient who had radiating pain and tingling in her legs, as well as intermittent bladder incontinence with standing. So she was symptomatic from spinal cord compression in that regard. Just a couple other things to point out about this patient. She has transitional segment anatomy, but they managed to get some sort of an interbody in anteriorly. And I was always curious as to how, and some of you may be as well, but the operative reports were buried deep in the bowels of Missouri. So we couldn't actually ever get them. But just to note that, it's going to be relevant when we talk about the finding that we depict here, which is a fractured right S1 pedicle screw. Transitional segment anatomy often means that there's a very steep medial inclination to L5 and S1. And in this particular patient, there was a very limited channel in which to place a pedicle screw. Having a fractured pedicle screw at S1 caused us a problem in planning our surgery because we knew that the patient was lacking adequate lordosis. So when we measure the pelvic incidence, we see a PI of about 46 degrees and a total lumbar lordosis L1 to S1 of about 24 degrees. And most of that lordosis was coming between L4 and S1. And so we know that patients are not obeying strict equations. We can't say that every patient should have a lumbar lordosis within 10 degrees of their pelvic incidence. It's not quite that dogmatic, and we need to do age-appropriate and pelvic parameter-appropriate adjustments for the lordosis. But just for the purposes of our discussion and simplification, we'll use in general that concept of for a patient with a mid-range pelvic incidence in this particular pelvic shape, let's assume we need to get the lumbar lordosis somewhere around 10 degrees of the 46. And again, pointing out the pelvic tilt here, this is something that's fairly underutilized in a lot of our trainees. It's not something that everyone likes to measure, but I point it out because this patient has a really verticalized sacrum. She's maximized her compensation here, and she's fairly locked in that position. And then I just also wanted to point out T2 to T10, how hard she's working to hyperextend here. And so you can understand if this patient begins to develop a progressive march of thoracic disc herniations, and you often see this in adult failure patients who have inadequate sagittal alignment. Even if they don't have a profound failure or a profound junctional kyphosis, they're required to hyperextend their thoracic spine in order to compensate for their lumbar deformity. And very often you can see progressive thoracic disc herniations, and maybe they'll come to you right away and you'll recognize the deformity. Maybe you'll get where someone has done 3 progressive thoracic disc herniations. But either way, it's something that you want to be aware of and look out for.
Kristen, thank you so much for highlighting that. I think you know, you're absolutely right. A lot of folks kind of focus on the sagittal balance, the SVA, the PI, and they forget about the pelvic tilt. And you're absolutely right. The pelvic tilt is very important because it can basically obscure or hide a terrible deformity if they're retroverting. So they can actually give you a fake x-ray, or the x-ray may look better than what the deformity actually is with a high PT. So I agree with you. Thank you for pointing that out.
That's a great point. Another thing that I failed to mention, Suken showed us a lot of really well taken x-rays with the patients in perfect position. And the position of the patient for the x-ray is really important. Ideally, even though I showed you a picture where this patient had her hips flexed and her knees flexed, we want the patients to achieve full extension of their hips and knees for their films. Now, this particular patient actually could not and still remain in upright stance, but we're probably underjudging her deformity based on parameters that way as well. So just to point that out, it's important when you're looking at films to see the position of the patient. So when you're trying to solve an adult deformity problem, sometimes if you try to think about all of the problems at once, it becomes fairly overwhelming as far as what to solve first. So I'd just like to present a strategy that we commonly use here. And again, I was lucky enough to do my fellowship in orthopedic spine under David Pauly, and he has a very systematic and stepwise approach to these problems and very thorough. So basically what I want to start out with is talking about what's there, what's fused, and what needs to change. So what's there, or T12 to iliac. What's fused, I'm going to give you the answer because you can't see too well in the CT scan. But before I give you that answer, just as a poll through the audience, what does everyone make of seeing air in the disc space at L4-5 in a patient who had an A-lift there about 10 years ago? So any answers for that? On this CT scan, on the sagittal scout, there is air or black density in the disc space and around the interbody at L4-5. And so does that give anybody any ideas about what that might mean?
Yeah, several folks are responding with concerns for pseudarthrosis.
Yeah, it's excellent. So again, it's a little bit of a giveaway with a broken rod and a fractured screw, but even if you didn't see those things, if you see air around an interbody in a patient who does not have discitis and who does not have recent surgery, you know there's a pseudarthrosis there. So that's something to be looking at. Just like if you see advanced degeneration in any disc space, you see a lot of air there. So just wanted to mention that briefly. So going back to our strategy about what's wrong and how we're going to fix this, we obviously, our eye goes right to here, and what are we going to do to salvage the spinal cord from the magnificent banging it's undergoing every time this patient stands up? But in order to adequately fix the proximal problem, we have to fix what got it there as well. So this patient has the proximal problem or the junctional failure because she's overcompensating for distal malalignment. So what we want to achieve is fixing her lumbar lordosis to a more optimal parameter, and also, of course, repairing and stabilizing her proximal junctional failure. And anytime we see a pseudarthrosis, we're going to address that. And so we want to reach into our toolbox here and start to evaluate what tools we're going to need in order to fix this problem. So I will tell you that even though the patient had a pseudarthrosis based on that interbody appearance and the broken rods, she is very rigid throughout her lumbar spine. And I bring that up because when you consider what type of deformity correction to perform, you have to consider how rigid the patient is. And in a patient who is both instrumented and fairly rigid, you're going to have to reach deeper into your toolbox. And by that, I mean by the SRS Schwab osteotomy grade, you're going to be reaching into grade 3 or higher if you've got a patient who's fused anteriorly. So a Schwab grade 3 osteotomy, commonly known as a pedicle subtraction osteotomy, is what I'm referring to here. And one thing that's a little tricky about this case, and that has to come into play with every deformity case you do, these are very powerful correction tools, doing a 3-column osteotomy, essentially disarticulating the patient's spine and putting it back together. And you want to be very careful not to overcorrect the patient, because that's very easy to do. So here we notice that the patient's pelvic incidence is about 46 degrees and her overall lumbar lordosis is 24. The majority of her lordosis does come from L4 to S1, and recent studies have shown that that's exactly what it should do. In a patient with a mid-range pelvic incidence, her about 50 degrees, would want about 2/3 of her overall lumbar lordosis to come from L4 to S1. So she's not quite there. She's at about 50% coming from L4 to S1 and overall lacking some lordosis. But this is nowhere near the most profound sagittal deformity we'll see or treat. So it's very careful to be it's very important to be careful of those numbers and dial in the correction appropriately, and not just go in with guns blazing because you're going to do a 3-column osteotomy. So you have to be measured here about what you're going to do. And one of the most important things is supine films. So supine films are going to show you how flexible the patient is. I often will get supine x-rays if I don't have a CT scan or an MRI available that crosses the area of interest. But if I have a CT or MRI, that's my most perfect supine film, because I don't know what your radiology departments are like, but in our radiology department, our patients have to lay there a little bit before they get their scan. So they've got the most relaxed supine positioning we're going to get, and that's a fairly good predictor of what we're going to find when we position the patient prone in the operating room. And Dr. Lenke talked about that a great deal in just talking about how you plan for your correction. You need to evaluate the mobility of the deformity. That's a great way to do it. So moving forward, I do want to take another audience poll question, and we're gonna need to do a 3-column osteotomy here. And there have been multiple papers published recently that show that 3-column osteotomies, like pedicle subtraction osteotomies, are subject to a high degree of complications, including rod fracture or pseudarthrosis as high as, above 40%.
I think
So
we're going to
there are
take a
multiple
question,
strategies to try to mitigate that. And I'd just like to ask everybody which ones either you've seen or you routinely employ. And I'm going to focus today on strategy point A. And that's something that's probably one of the least common of the options chosen. But I'd just like to show it to you as another element in your toolbox to have. Coy, if you want to jump in and let me know what people are saying, that'd be great.
Yeah, there are a few questions.
Yeah, we have a few questions, Kristen. So one question from Dr. Gilroy is whether you're using the Rousseli classification in your decision-making.
Absolutely. Yeah, we definitely want to consider pelvic shape and pelvic parameters. We definitely could talk about that, and even that's an evolving consideration and understanding as we're speaking, but definitely that's a very important thing in order to find out where someone's apical lordosis should be.
Another question from a couple of folks is how you select the level for your PSO.
That's a great question. In general, we want to think about which area of the lumbar spine we need to achieve the most lordosis. So this patient has about 50% of her current lordosis between L4 and S1, and we know that we want to achieve about 66, 67, 68% of her lordosis there. So we're going to choose to do our osteotomy at L5 in this case in order to get more lordosis there. And just to show everyone in this zoomed in photo here, this patient has anterior interbodies at every level. She has, of course, integrated screws at L3-4 and L4-5. So if we discuss on whether to do the PSO at L4 and L5, number one, pelvic shape comes into consideration. But absent that, when we're considering doing a PSO around anterior instrumentation, we also have to look at the corridor available. So the corridor available to do the PSO cut here, if we were going to do an L4 PSO, is slightly truncated by the reach of these integrated screws here. Whereas here at L5, we've got a window where we can go through the pedicle, past the integrated screw, and come out just above the level of the disc space here. So that's one thing that goes into consideration in planning these complex 3-column osteotomies in patients with anterior instrumentation.
And I have one more question for you before we talk about your pull. I'm interested in your decision to stop at T10, just with how far forward the remainder of her thoracic spine is located. Can you talk about how you decide to stop short versus go long?
That's a great question. And that leads into discussing the interbody approach, the transthoracic approach. So in general, the standard strategy to fix this would probably be to extend the patient up to the mid or upper thoracic spine. And many of our training, it was fairly dogmatic. If someone fails at T10, you take them up to T2. And maybe that's not the end of the world. As Suken told us, there's not a lot of mobility in the thoracic spine. But one thing it does add is operative time and blood loss. And every time you're placing a screw at a thoracic level, you're taking a risk of that screw not being where you want it to be. So in general, if we can mitigate extending up high, we do. And one way that we've done that is with the technique that I'll show you. When we do 3-column load sharing in the thoracic spine with the interbody fusion at the upper end of the construct, we've done some biomechanical modeling in concert with work by Carl Eric Aubin that shows us that we can actually create better load sharing throughout the spine and decrease the proximal junctional failure loads.
Great. So, most people for your pull are choosing B and C. You want to tell us what you did?
Sure. So we did A, and there's nothing wrong with B and C. Those are great answers as well. The important concept here is that if you're going to do a 3-column osteotomy, you should have more than 2 rods across the 3-column osteotomy site. And before we just go into surgical technique, very briefly, I know every institution does this differently, but we do a complex spine multidisciplinary conference. It's very important to try to optimize risk factors that you can actually improve prior to surgery in order to reduce your complication risk. So this patient did have osteoporosis. She was placed on an anabolic bone density agent prior to surgery, multiple cardiopulmonary risk factors. We really like to use tranexamic acid, high dose in most of our adult cases. This patient had a history of a cerebrovascular accident, and so of course we wanted to ensure we weren't giving her an inappropriate clotting risk. Nutritionally, we always do a prehabilitation, and we like aquatherapy or recumbent biking because no matter your deformity, those are fairly well tolerated exercises. And we always want to check for hypoalbuminemia. It's sort of the silent killer of adult deformity in the sense that you're almost guaranteeing yourself a wound complication, whether it be simple dehiscence or prolonged healing, or whether it be outright infection if you don't optimize the patient's nutritional status preoperatively. As Dr. Shaffrey likes to say, just because someone walks into your clinic with 2 liters of Mountain Dew and a giant bag of Cheetos does not mean that their calories are sufficient for good nutrition. So, and again, another thing to point out, there are several interesting studies that show that the more drug allergies that you have above a certain threshold can actually indicate mental illness. So this patient had 13 drug allergies, also had a history of depression. We sent her for behavioral health management. Another important thing is morphine milliequivalence. A patient with a substantial amount of morphine milliequivalence will not only have difficult pain control postoperatively, but can have a paradoxical reaction where it can become nearly impossible to adequately manage their pain. So we always wean the patients preoperatively, and that's definitely the most popular part of my practice, is when I tell people that they're going to get their narcotics weaned before we do surgery. I don't know how everybody else feels. So after optimizing this patient, of course, as expected, she only gets worse with her ODI. It goes up to 62, but at least we're feeling better about our chances for the following surgical plan. So talking about the setup in the operating room, we always do these cases that are involving instrumentation in the thoracic spine or 3-column osteotomies with neuromonitoring. By that, I mean somatosensory evoked potentials and motor evoked potentials, as well as free-run EMG at the levels of the intended osteotomy. We guide our intraoperative transfusion based on thromboelastography. There are many different ways to do it, but that's one way to help avoid overtransfusions. We use a cell saver device to allow for routine readministration of blood loss. So in general, our surgical plan here, we're going to remove the instrumentation that's there. I didn't show you this well, but a lot of these screws are haloed with significant lack of purchase in the pedicles. So we're removing the screws and replacing them with larger and longer screws to try to increase vertebral body purchase. And we're going to use S2AI screws for pelvic fixation here. Her iliac screws are also slightly haloed. We don't want to overshoot it with our PSO. We don't want to get more than about 20 degrees, because if we overcorrect someone, that's almost as bad as undercorrecting them. So we want to be careful with what we get in our 3-column osteotomy. And how are we going to repair this area? Well, I mentioned we want to know what it does when she turns supine or turns prone, and she actually reduces about 20 degrees just by positioning alone. So we'll be left with about a 20-degree deformity here. And when we consider how to correct that, we in general can get about 10 degrees of correction per level of posterior column osteotomy and thoracic interbody. So we chose to plan to extend her for 2 levels, of course more if we have any problems intraoperatively, but that was our sort of our beginning plan. So you go to the operating room with plan A through plan F, and you end up with something that works. And then, so just a couple points about each of these steps. We're not going to go through them in great detail. One of the reasons we wanted to get this broken pedicle screw out was because this was at S1, which is the level just below our 3-column osteotomy. And you want to get good fixation adjacent to your 3-column osteotomy, knowing that you're going to have high translation and motion forces across that. So we wanted to get this screw out, and because of the transitional segment anatomy, there really wasn't a good channel to put a different trajectory of screw in. So there are a lot of different ways to extract a screw, but a particularly effective one to avoid overboring the pedicle out and losing purchasability is to use a trephine. And we basically used a 7mm trephine around this screw, extracted it, we were able to put a larger, longer screw in with good purchase. So just wanted to mention that briefly. And you can see with the instrumentation that she had out in this intraoperative view here, the corridor that we're starting to see open up through which we can do our 3-column osteotomy through the anterior instrumentation. Want to point out here in the AP view are dual-headed pedicle screws. So the dual-headed pedicle screws just allow you to easily connect satellite rods at the end of the case without having to use domino connectors, which can be sometimes tricky to put in and connect when the screws get very close to each other after doing a 3-column osteotomy with a lot of correction. It's also just one more thing to fuss with at the end of a long procedure. So we find this makes it very easy. It also assists us in controlling translation of the osteotomy site itself. So just wanted to mention that. And the dual-headed screw looks just as it says. Here you can see 2 heads connected to 1 screw shaft, and we put that at the level above and the level below our intended 3-column osteotomy site.
Dr. Jones?
Yes.
A few questions.
Sure.
One from Dr. Selby, who I think is out of Australia. How do you assess for L5 vascular safety with prior anterior surgery?
So that's a good question. In general, we don't do a dedicated vascular study when we're doing an L5 PSO. We're planning on leaving whatever is anterior intact. So we're not going to move the anterior instrumentation itself.
Great. And another question was how you, I guess, sort of counsel patients when they take this sort of full year to get optimized. Any concern with that, particularly if they suffer from a fall?
Yeah, absolutely. A patient who's floridly myelopathic is not someone we're going to be able to pre-optimize for a year. And recognizing if there's an acute neurologic deficit or a neurologic decline, we're going to have to take care of the patient sooner. And that's always a concern we explain. In general, I am fortunate to be able to say, and I'm sure tonight I'm going to get 3 patients come into the ER who I'm preoperatively optimizing just because I'm saying this, but I have yet to have a patient have a neurologic injury because we waited too long to do surgery. So it's an important consideration, but in general, if they're not floridly myelopathic, we can wait.
Great. One more great question from Dr. Kolakowski is how do you judge whether the thoracic kyphosis will adjust to the lumbar lordosis that you're providing?
That's an excellent question. So in general, there are multiple different software planning devices that you can use. I use SurgiMap, and it's very effective for being able to see what reciprocal thoracic change you can expect and what you actually want to get, so to help you dial in your correction. That's a very important point where you don't want to overcorrect the patient and then end up with reciprocal overcorrection in the thoracic kyphosis and hyperkyphosis.
Great, thank you.
Okay, thank you. So moving forward, I know we're getting short on time, so just briefly, I put these red arrows in to help to show you where we put our osteotomes to make our PSO cuts. And so you can see we want to be really careful. This is perhaps too steep of an angle here, but we're only shooting for about 20 degrees. So we plan for around 25, and we can we cannot close that fully. We don't want to cut too short to start with and then have to do another cuts again, because that's obviously going to add significant time and blood loss. And the rule of the 3-column osteotomy is once you start, it is absolutely going to bleed. And so you just finish as controlled but as progressively as you can. So we plan these cuts. And actually, one of the tools that we use that's very helpful is using image guidance with an osteotome that's image guided. You certainly don't have to. You can use fluoroscopy with regular osteotomes just fine. But one of the premises here is if you're going to make cuts around anterior instrumentation, you want to know where that instrumentation is relative to your osteotome before you hear the sound of metal on metal indicating you found it. So you want to plan this very carefully. And so I'll just move forward. You can see here, we got somewhere around 20 degrees when we closed. We actually thought this was a little too much and backed off a little bit. We didn't want her quite so lordotic. That's a good problem to have when you have too much correction available to you. But as I mentioned, it's a dangerous tool, and you have to be careful not to overcorrect the patient. So I want to move on to the thoracic interbody fusion and pontiostiotomy part of this procedure. Whether you call them pontiostiotomies or Schwab grade 2 osteotomies, posterior column osteotomies, the premise here is that we're resecting all of the posterior elements to allow for full mobilization of the spine. We're going to add anterior column support, and we're going to be able to compress posteriorly to take full advantage of our anterior column. And so here, in general, multiple different steps, and Suken showed this very well already, so I won't belabor the point. Resecting the inferior articular process, fully resecting and releasing the ligamentum flavum. And just a pearl here, to do a thoracic interbody fusion, it becomes very key to resect the superior articular process flush with the pedicle, right about the level of this star here. You really want to get it down flush with the pedicle completely so you have full access to the interbody space from the transforaminal region. And also there's going to be a little tip of SAP left up here almost always. And I have had a patient where we left a little tip there, developed a thoracic radiculopathy from it. So you want to be very careful to resect that SAP, and here's a picture of resecting that there. All lessons are often learned the hard way in adult deformity surgery. So just continuing along with several technique steps. So here's where we start. This is intraoperatively with the patient on the table, the screws in place. And I want to point out that we typically use an interlaminar distraction. So this is a wheeled laminar spreader. You can certainly use pedicle to pedicle based distractors, and sometimes we have to, like in this picture. But in general, we try to avoid putting forces across the pedicle screws themselves, because sometimes that can loosen the purchase, specifically in patients with bone. So this is basically we've performed our posterior column osteotomies, we've done bilateral discectomies, we've put our distracting trials in the disc space, we've done full discectomies. We progressively size these up. We are not aggressive with the size. We're not trying to significantly increase the disc height here. We're trying to mobilize basically up to the anterior column of the spine to allow us to effectively compress and reduce the deformity. So here you can see the bilateral cage inserted at this level, techniques repeated at this level, and here's our final result. You assess your on-table correction, make sure you achieve your goals. And we've locked in this patient. This is her 2-year post-op x-ray, and she's doing well, fortunately, for now. So it's adult deformity. We'll see.
That's that's a really great result, and thank you for going through that, Kristen, step by step surgically. I mean, these were some of the most challenging procedures. I apologize, we are running a little bit short on time, so I'll ask Koi. Oh, that's wonderful, great. So perfect timing. Koi, any last 1 or 2 questions from the audience, and then and then I'll have one question for both speakers at the end.
Let's go with the final 2 questions for Dr. Jones. Can you just remind us what you did to help prevent PJK for here? Did you use the banding?
Actually, we did use tethering. Yes, that's correct.
Great. And then when you're doing these thoracic interbodies, do you sac the nerve roots, or you leave them?
No, we always leave them. Never had to take a nerve root for this.
Great. That's all. That should be everyone's question.
Okay, great. Just one last question real quick for both Suken and Kristen. We'll start with Dr. Shah since he started. When do you use navigation, Dr. Shah, for your cases? Always, never, sometimes? And then same thing for Kristen.
Not really for AIS. We would use it for complex cervicals, sometimes for very bizarre congenital anomalies where we're planning a big resection. But most oftenly, I would say we use it for revision cases where the posterior landmarks are obscured by the previous fusion. The anatomy is quite bizarre, and our typical anatomic starting points don't exist. I think navigation is a great tool in that scenario.
And Kristen, for you, do you always sometimes or?
Nearly always. I think it allows us to help our trainees do more. We want to make sure they know how to use spine instrumentation without navigation, but it's a great way to accelerate the learning curve as well.